then we'll go live. It's all coming back to me now. Hello, welcome to the Health, Occupations, and Long-Term Care Subcommittee. Sorry, we're getting started a couple minutes late today. We will be running this subcommittee until 12:30, and we will get done with as much as we can get done. We have 8 bills on the agenda today. I'm hoping we'll be able to pass out at least the first 3, and the rest we may need more time for conversation on. So the bill order we're going to do is HB 229, HB 1051, HB 636, then 747, 830, 911, 972, and 1034. So with that, the first bill we're going to be discussing is coming back to us from last week, HB 229, Pharmacists, Administration of Maintenance Injectable Medications, Treatment of STIs. The committee will remember that when we discussed this last week, we sent the stakeholders, particularly the bill sponsor and Matt Celentano, off to work on an amendment for this bill that has already passed the Senate. Would you like to, Delegate Lewis Young, give us an update on that conversation?
Sure. We have worked diligently and had numerous conversations with all the stakeholders, including the Senate cross-file, so that we don't have to end up in conference again. And basically, the League of Life had concerns relating to the codified definition of maintenance injectables that this bill originally proposed. They submitted the amendments before you, which we now deem as being friendly. The language was submitted to address the concerns. There won't be any premium hikes. I just want to address one other thing. You mentioned the fiscal note. When the, I would say, grandmother bill passed last year, the fiscal note writer indicated that the provisions and training requirements needed could be enacted with existing resources. So if the much greater bill could be enacted with existing fiscal sources, I don't believe that just adding STIs on would propose an incremental fiscal requirement.
And Lisa, I'm sorry, I didn't mean to bypass you, but is there anything technical you need to make sure the committee knows about the amendment before us?
I mean, do you want me to run through what the amendments do?
Sure, great idea.
So there is a reprint of the bill with the amendments that starts on page 2. The amendments require, and this would have been the same when we put originally when this was included into the definition of maintenance injectable medications, that's covered by Medicaid. So this is, though, since we are now adding a new definition for injectable medication for treatment of a sexually transmitted infection, we had to go through and put that everywhere in the code where maintenance injectables were in last year's bill. So we had to add some provisions to the Medicaid article. Then there is the new definition of injectable medication, which you can find on page 4 of the packet. The amendments also authorize the pharmacist to administer an injectable medication for the treatment of a sexually transmitted infection. They require the carriers to provide coverage for the administration of an injectable medication to the same extent as services rendered by any other healthcare practitioner. And then there is also the idea behind the first bill was that they wanted, I guess there was a belief, and I think it's true, that the regulations for maintenance injectables would be the same as for injectable medications to treat sexually transmitted infections. So there's some uncodified in the language that says that rather than the board having to go back and start the regulations from scratch, that they should use the regulations that they have implemented in the past year since the grandmother bill, as Delegate Lewis Young referred to it, passed.
Thank you for that. I would love to hear from Matt Celentano and thank him in advance for working with the sponsor to work on these.
Thank you, Madam Chair. And as a fan of grandmothers, I do appreciate the opportunity to say thank you. Thank you especially to Delegate Lewis Young and her staff and Senator Lamb's staff across the street for helping me work through the issue, and for Lisa Simpson for helping us draft the agreed upon amendment and giving me the opportunity to say I support something. So thank you very much.
And also Aaliyah, I see your hand up, but I was going to call on you anyway. Thank you for being here, Aaliyah.
No problem. First, I would really like to thank Lisa for figuring this out. It was a little bit of a challenge to, we'll give her a round of applause. She earned her paycheck on this one. We are happy with it. We think it provides clarity on what's being asked. I thank you, Matt, for agreeing on this one as well. I think it just is very clear on what we're asking for. We also appreciate the fact that it references the regulations the Board of Pharmacy has already put into, it's in place now, it's out for public comment now. So when those pass, the STI issue can be addressed. It is our belief in reading it that the Board of Pharmacy does not have any additional work to do. It's just that pharmacists will also have to follow the same procedure. So we are pleased and happy to support.
Okay, and I don't see anyone from the Board of Pharmacy here. I think they are not here. I have not spoken with them directly. I do know I saw an email where they were expressing some concern about possibly this increasing a burden for them. Has anybody spoken with them directly?
I was going to say I have not. I did see the email with their concerns, and I was just going to follow up with them after this meeting to provide additional context, because I think there may have been a misunderstanding that they were going to have to modify the work that they've already put in or have to promulgate new regulations.
That was my understanding of that email as well. I think it was a misinterpretation of what we were doing because they weren't here at the last discussion. So I think we will be in good shape with them. I don't think that this is going to be burdensome for them at all. So I would be comfortable if somebody wanted to move this amendment. I think we did good work, and I'm glad that the senator is on board as well.
Madam Chair, can I move the amendment?
Absolutely. Okay. Moved and seconded. Any further discussion on the amendment? Delegate Krebs.
I just had a question, and thank you for clarifying the maintenance medication. But the way I understood it, the way I read this on page 2, line, I guess 19, it said some treatments are multiple treatments, like syphilis requiring 3 injections, and most others are single treatments. So if I read this correctly, it says a pharmacist may not administer an initial dose. So on all of these, the doctor is going to do the initial dose, even if it's a single dose, and then the pharmacist can do the subsequent doses. Is that correct?
I think it's determined by the physician. It's still determined by the physician who does the first dose. It's totally in the physician's hands.
I mean,
but the physician would have to be prescribing them. So at the time of the prescription, the physician's making that determination.
Yeah, either the physician is going to be going.
I'm just reading what it says, though. I mean, go ahead, Lisa, you can go. But I just read it. It says
my understanding is that the physician can administer the first dose or can prescribe the first dose to be administered by the pharmacist.
Which is the same as last year's bill.
Yeah.
Okay, so they may not administer it unless the board, in consultation with Board of Physicians, adopt regulations. So the board would have to adopt regulations to allow them to do the first dose. Is that what, I mean, I know what we think we agreed to. I just want to make sure that's what it says. Is that right?
If you read the rest of 19 and 20, under this section, unless the pharmacist receives written approval from the prescriber, they may not administer. And then 20 says 19 and 20, unless the pharmacist receives written approval from the prescriber.
Okay, so the prescriber can say, I want you to give all 3 of these or the initial dose of whatever. Okay, I just want to make sure I got
And
it
as
right.
I understand, my question is, I guess, to the sponsor, this in part is solving a problem that physicians know these medications need to be administered in a timely manner, but they're not stocking them.
That does happen occasionally, yes.
So the control is still up to the physician to
Yeah.
allow or disallow. Okay, I think you met a good compromise. Thank you.
Okay, so all in favor of the amendment, say aye, and if you're opposed, raise your hand. Krebs is your, Delegate Krebs is your hand is not up. Okay, so the amendment passes unanimously. On the bill as amended, do I have a motion?
Move the bill as amended?
Second.
Moved and seconded. Any discussion on the bill as amended? All in favor, say aye, and if you're opposed, go ahead and
Aye.
raise your hand so you can be marked. Wow, go team, good work, passes unanimously, one off. Well done. I'm very, very proud of the stakeholders for working this out. And of course, as everyone has said, again, Lisa, thank you. Number 2 on our list is at the bottom of our agenda, House Bill 1051, Elderly Individuals, Howard County and Montgomery County Adult Daycare Services Pilot Program and Task Force. Lisa.
This bill establishes the Howard County and Montgomery County Adult Day Healthcare Services Pilot Program to integrate the provision of medical adult daycare, home health care, and medical services provided under Medicaid. Howard and Montgomery counties may jointly designate and authorize the operation of one or more entities to serve as an integrator and coordinate all services provided under the pilot program.
Perfect.
Yeah,
Okay,
the bill.
go ahead. Sorry.
Oh, no, it also establishes a task force to help with the whole process.
Excellent. And we have some stakeholders here. I see Joan Smith and Bryson Popham here on this bill. I don't think we have any amendments to discuss on this bill. We do have a letter in the file from Montgomery County. We don't have a copy of the letter from Howard County, but we are expecting it soon. I spoke with the chairman who has assured me that that will be coming. So just in consideration of our workload, I would ask if it's okay with the committee with the understanding that we do expect that that is coming to acknowledge that the support of Howard County. Let's hear from Bryson. Go ahead.
Madam Chair, thank you, Madam Chair, members of the subcommittee. Bryson Popham, representing Savita Health. As Chair Kelly mentioned, my colleague Joan Smith is with us today. Chair Kelly, as much as I would like to say the bill's ready to vote, there are a couple of possible amendments coming from the other side. I'd like to describe them to the subcommittee with your permission.
Sure.
One of them is very simple. It's an addition to the task force. My colleague Joan Smith has worked with you on another bill, Chair Kelly, with the Alzheimer's Association, and they would like to have a representative on the task force. So we will have an amendment for your consideration.
I did know about that. You're right. I'm sorry we don't have that for the packet. It's
Okay.
Go ahead.
The other amendment is we would consider it a friendly amendment. I know that Senator Feldman does, and my client would as well, but it's a little more substantive. The subcommittee may recall that you have in your file a letter from the Department of Health that says, among other things, that the program shares features of the PACE program. And the PACE program, as the subcommittee knows, is a very intensive, extensive health benefit plan is really what it amounts to for Medicaid beneficiaries. Senator Augustine quite properly said, whose district I think is going to be the next recipient of a PACE program, said, well, is there any duplication here? Is there anything we need to be concerned about? And what we agreed to conceptually, we have to get the language to him, is to include in the study that is called for under the bill a comparison of the pilot program with the PACE program to be sure there's no duplication. So we're working on language for that. As I said, we would consider it to be a friendly amendment, but we've got to get that, as I'm sure you can appreciate, to Senator Augustine first, and then at the same time over to you and your subcommittee. That's
okay. So let me propose this then, because as I mentioned at the top of the meeting, we're getting pretty backed up.
right.
I'm going to recommend that we wait for the Senate. We're expecting them to adopt the amendments and then move the bill, Bryson?
That's correct.
Okay, so let's wait. If this works for Lisa, let's wait and make sure we have the amendments straight. But let's go ahead and have the committee ask any questions they have in general about what we're expecting the amended bill would look like, so that we don't have to bring all the stakeholders back for continued conversation as we're getting busier. So we won't vote on this today because we don't have amendments before us. We don't need to vote on amendments and concepts, since they're, at least one of them is we don't have anything remotely like language in front of us. But at least we can see if there's questions from the committee on what the bill will look like as amended and how it will work. Delegate Krebs.
Thank you. And I appreciate the study, because I think a lot of times we just do things and they don't look back. So as part of that study, would it be that we're going to look at the two programs and then see how we're going to roll them out to the rest of the state? I mean, is that the end goal? I would think, to have access to these programs everywhere. So would that be part of the request in the study?
I think that is correct in concept, Delegate Krebs. I don't know if the specific language says addresses implementation statewide, but certainly that's the concept. The study has to go to you and your colleagues for determination whether to implement it statewide.
Well, and what I would just suggest is that would be a goal, that with the intention of eventually having a statewide program, just so it's known. I mean, it's hard for me to go back to my folks and say, hey, we're doing this study of these two wealthiest counties in the country, but there's nothing in it for us down the road. You know what I'm saying? But just at some point, you know what I'm saying? So at some point, the intention is that we're going to take these two programs and we're going to study them and then have a plan for how we're going to roll them out statewide, especially to the poorest of counties where there's real need. But that I would appreciate this, some type of recommendation back to us, so that we don't have to like reinvent the wheel. I won't be reinventing the wheel because I won't be here, but when the report comes back, it'd be nice to have some indication what the possibilities would be.
I'll be happy to work with our sponsor who chairs this subcommittee on language.
No, thank you. I appreciate that.
Excellent. Any more questions from the committee? Okay, well, it sounds like we have our marching orders and a plan. We will follow the lead of the Senate on this and make sure that Delegate Krebs' issues are addressed in the study as well, and bring this back when everything is tied up and we can take care of it. Thank you all. Okay, let's go back to House Bill 636. I don't know how much time we want to spend talking on this, because we did talk about it a lot. So we don't need to rehash why the stakeholders are interested in it. The issue still remains as to if the capacity exists to do the study. So I think the committee needs to, I guess, flesh that out and decide what we want to do with this. So we do have stakeholders here. I see, sorry, there's so many people this week. I see Dana, I see, I think I saw Eric here. I don't know if Ben Steffen's here or not. Sorry, too many bills this week. Do we have questions from the committee on this bill? I don't see any questions from the committee. How does the committee feel about moving the bill, does anybody have any opinion they'd like to express about what we should do with this bill?
Delegate Kelly, is it okay if I jump in really quick?
Please do.
Thank you so much for your work on this. Where we're really at is we just have to make a decision. Nothing has changed. MHCC told us they were in support of the bill. We wouldn't have put this bill in unless we had all the stakeholders on board. So we went in with good faith on this bill. Nothing has changed. They're holding it up with concerns of capacity and the amount of study bills that will come out of the General Assembly. My hope is that this subcommittee would prioritize this bill. It's really important, and make the decision to move favorable on it.
Okay, and I'm hearing that Tracy DeShields is here. I just have too many pictures. There she is. Hi.
Hi, how are you?
Yes.
The MHCC, yes, we do have concerns about our staffing capacity and resources, but we do feel that this is a valued study. And so, and I believe we are in a posture that we would do the study. The issue is, as you know, that we do have many things coming our way over the interim. So that was really all that we pointed out. One of the things we just pointed out in our letter of information, and that was it.
Okay, that's actually very helpful and clarifying. Let's hear from Delegate Cullison and then Delegate Bagnall, and then we'll go to Dana, who has her hand up. Go ahead, Delegate Cullison.
Thank you, Madam Chair. I'm wondering, and Tracy, this may be for you. Sorry about the lights. Hold on.
It happens in my office too. It's so hard.
Okay. Would a little extra time help? Is, I don't have the bill in front of me, but so I don't know what the reporting deadline is on this, but I'm wondering if there is an openness to making the timeline a little bit longer on it.
Yeah, we also have Paul Parker, who's on instead of Ben. He's our director for health planning. So the study would fall under his shop. I think more time, of course, would certainly be helpful for us. Paul, any thoughts? He's somewhere.
There he is.
No, the date currently is October 1st, 2023.
Oh, it is
October.
2023.
Okay.
Mhm.
Oh, then I think that's probably about as far out as we can go. It wouldn't be discussed then until the 2024 session.
Okay. Paul,
Yeah.
are you good with that?
Yes, I am. We are grateful that this is not going to be due until the latter half of 2023.
Great. Thank you.
Delegate Bagnall.
Thank you, Madam Chair. And I think Delegate Cullis and I share a brain, but I think given that we have sort of pushed this out as far as possible in terms of reporting, that this does need to be a priority. I mean, this is a space that we haven't done a lot of work in. It's a problem that has been recently identified, and we don't really have solutions because we don't have the data. And as this committee likes to say, we need the information, we need the data. So I would encourage us to look at this as a priority, knowing that that we're going to be reinventing a lot and learning a lot just as we're emerging from COVID. And I think this actually does fold well into the work that we're already trying to do.
Let's hear from Dana Kaufman, who has something to add.
Oh, thank you very much. And really what I just want to add is actually what Delegate Bagnall just said. I think that this has to be a priority. This is an issue that, for lack of a better term, we keep kind of kicking down the road. And I think that given some of the other changes, the revisions to the assisted living regs and some other bills that you have before you, that the time to really start doing this and deciding if this is how we regulate these smaller providers and what resources we can provide to them for better care is extremely important. So I would urge that this bill be voted favorably.
I tend to agree with the folks who have spoken before, and just would note that I think that it's nice to have the stakeholders on board saying the same thing. Do we have any other comments from the committee, or do we have a motion on the bill?
I'd like to move the bill, Madam Chair.
Second.
Moved and seconded. Any further discussion on the bill? I will just say thank you to the MHCC. We know we're piling mountains of work on you, and you do great work, and that's the the reward you get. I apologize. All in favor, say aye.
Aye.
Aye. Anyone who's opposed, raise your hand in the chat. Looks like it is passing unanimously. Go team. All right. Let's move on to House Bill 747, which is Delegate Kerr's bill, Maryland Healthcare Commission Nursing Homes Audit. Lisa.
This bill requires the Maryland Healthcare Commission by December 1st, 2023, and then annually thereafter to conduct a comprehensive audit of cost trends, labor issues, and financial performance for each licensed nursing home in the state. There are amendments on page 7 of your packet, and the amendments strike the bill and replace it with an annual reporting requirement on changes of ownership, trends in utilization, and financial data.
Okay. Delegate Kerr, do you have anything to add?
Thank you, Madam Chair. I was just remind the subcommittee that this bill is important because of the increased importance that our aging population is going to place on all aspects of Maryland's economy and healthcare system, and that with so many of our nursing facilities transferring ownership into out-of-state companies, we need some additional oversight just to make sure that the quality of care is not slipping, and that we're doing the right thing. And we do have some of the advocates here today who are also available to provide any additional information to you.
Excellent. Thank you. I see hands up already from Dana Kaufman and Stevan Ellis. So let's go to Dana first, and then we'll go to Stevan.
Thank you. I don't know if you want to take, I'm actually going to speak against the bill, so I don't know if you wanted to take.
So
the
should we
advocate
hear from
first.
Claudia first? Or who can, Delegate Curra, who should we hear from first?
We should probably hear from Claudia Baylog,
Okay.
and then Stevan as well.
Okay, go ahead, Claudia.
Thank you, Madam Chair. So I would just add, because we are, first of all, so appreciative of the work of MHCC, and we've had conversations, and we also support the assisted living facility study and view that as a priority from the 1199 perspective. I would just add that, the amendments that were submitted for this bill no longer put any kind of onus on the state to conduct an audit or anything that's duplicative. It really is about taking the information that is held by MHCC and making it transparent to the public. So for example, when there's a requirement for a report that includes changes of ownership, the state does maintain a list through the Office of Healthcare Quality on the changes of names. When a nursing home changes hands and they have a new name, that's reported on the Office of Healthcare Quality website, the CHOW dashboard to be specific. But that's not the same as a change in ownership. So for example, if facilities move to the new name of Peak Health, nowhere on the state dashboard does it say that's actually a private equity company called Porta Piccolo. So what we're really just seeking is sort of a centralized place, and we're really, cognizant of the pressures on the state across the long-term care spectrum and assisted living and in nursing homes, but really just seeking to find a way to get usable data, whether it's data that's already used by the MHCC in their health planning analysis. There's all kinds of public use files that are really incomprehensible to the public, or whether it's compiling transfers and ownership in one centralized place. So I would say, we come to this in the spirit of understanding that there's a lot of pressure to do a lot of things right now, but this is important. It is important for stakeholders to understand the financial stability of our existing Maryland operators who are good operators, so that we can make decisions and we don't see out-of-state bad actors come in and take advantage of conditions of the nursing homes in our state. So I'll stop there. Thank you.
And can you give us an update, because it sounds like while the amendments are fundamentally change things, we still don't have everybody on board. So is there more work we need to do to get people on board, or do you think we're just not going to be able to do that? Or do you have thoughts on sort of what we might be hearing coming after you?
I certainly, I know Dana will speak to some concerns that this bill is duplicative. And I think, we can sit down and see what's duplicative or not. But as these amendments are written, I don't believe we're asking for duplicative information. We're really asking for a new way to create a dashboard for public use on financial transparency in the industry.
Excellent. Thank you. Before we go to Stevan, I'm just going to tell the committee I started my timer again. We have 1, 2, 3, 4, 5 bills and about an hour. So I'm going to give each bill 10 minutes. So I started it late on this bill, but I'm conscious because I know we have stakeholders here for a lot of bills. Stevan.
So thank you very much. And I want to ditto to Delegate Kerr's comments and Claudia's comments as well. I think that the information that is publicly available is very confusing to the public, to consumers and to stakeholders. And also, again, as Claudia said much more eloquently than I can, that we need a little more detail and different information. The child dashboard is helpful, but it doesn't reveal as much information about the owners. And we definitely don't have any public information about how the costs, what they are, how they impact the budget, how they impact patient care. And so I would have preferred Delegate Kerr's original bill if it could stay in that form. However, I think the thing to keep in mind as we think about this is that it's all about the quality of care for the resident. And we've seen lots of studies nationally. My peers that are state ombudsmen across the country have seen this. Private equity companies, REITs, those type of things, they tend to be more centered on profit, and patient care goes down, quality of care goes down, bad outcomes. And so it'd be nice to have a study to look at that in Maryland to see how cost and how expenses are made, how they equate to good patient outcomes. And if private equity companies do great in Maryland, we have good outcomes, that's different than, and then we could look at that. But we really don't have the data to figure that out yet here in Maryland. And I think that would be a great benefit for the residents. We do have some concerns about companies that come in and seem to be more profit-minded than patient care. And we're looking at those as a program to see what the trends are. And so we're, dealing with resident concerns and that sort of thing. But I think transparency is what we need. And I think this bill would be a great start in that. And I think we can work together, the industry, the stakeholders, the advocates, to really come to some sort of agreement. But again, my preference, I like Delegate Kerr's bill. So thank you all very much. And thank you, special thanks to Delegate Kerr.
Excellent. Anybody else here who wants to speak in favor of the bill we have before us before we hear from Dana? I don't see anyone else. Sorry, it's just so many people today. Dana, go ahead.
Thank you. So with all due respect, our biggest concern is we don't think that this bill is actually going to do what everyone keeps saying it's going to do. Like, I've heard terms like database. This bill isn't a database. It's requiring the Maryland Healthcare Commission, who honestly doesn't have this information. They would have to get this information from the health department. So I'm a little bit concerned because we've just had conversations about how much we're putting on the commission. But like, for example, when we talk about CHOWs, those are changes of ownership. This bill says that they just have to report each change in ownership. That is actually what the OHCQ dashboard does. That dashboard doesn't just say a name change. That's a completely different item. A change in ownership is a 25% or more. And that's what that board does, or that page does. And that's what's listed on there. So all this is going to do is duplicate that, because all it says is each change in ownership. It doesn't go into any details of what that change of ownership is. So that's a concern. And then when you look on page 2, it talks about a summary of the financial data and cost reports. Cost reports right now are used for rate setting. They're done by Medicaid and they're reviewed, and the rate setting is set by Myers and Stauffer, which is a third-party vendor. So that information then would have to go to the Maryland Healthcare Commission, but that information only provides a snapshot of limited information. The financial data doesn't say, the acuity of the patients, which, we have to report on a different reporting mechanism. It doesn't talk about independent wages. It's all aggregate. So to me, I'm not exactly sure what the means to the end is here, because we can put all this data out, but if it's not a purpose for it, it's just data. And the cost reports are already publicly available. If you want to get one, you can ask Medicaid for any of the individuals. So for the nursing homes, this isn't a burden because this doesn't have anything to do. We don't have to do anything here. My concern is that the information isn't getting, I think, to what we're trying to achieve. And I'm not sure what that is right now. I mean, I know everybody wants to have a better financial picture. I don't think this is it. And as far as private equity firms, anybody who watched the State of the Union and read President Biden's press release, CMS is going to be putting out new regulations and information on private equity firms. We share that concern. We actually, Lifespan had conversations over the summer with both OHCQ and the Maryland Healthcare Commission on changes of ownership and how we could tighten that up, what we could do. So we're on board with that. But again, I'm just not sure that this bill is doing what we think it's going to do. I think it's going to add and take away on state resources. Not sure how to actually fix it in the time that we have with everything else going on.
Anybody else from the stakeholder side who wants to speak on concerns with the bill? I don't see anybody else. Do we have questions from the committee for either the proponents or for Dana? No questions at all. Delegate Krebs, how are you?
I don't want to let you down.
Thank you. I'm going to miss you.
Somebody else wants to ask a question, I'll be happy to defer. Is anyone here from the Healthcare Commission?
I know Tracy DeShields is still here.
And Paul Parker is still here too.
Okay, and thank you. And thank you. You guys did a very excellent letter that gave us a lot of information of why you think some of it's duplicative, but we have an amended bill in front of us. Can you talk about the amended bill and your opposition, and if it changed or got modified, or is there any value to any of this, and what we're trying to accomplish? Is there any value in any of this, given the amendments and what your opposition was? And I thank you for, like I said, for having it in writing.
The amendments to the bill, we think, do definitely make it a more realistic bill. The idea of an audit, at least as that term is understood in conventional cost accounting, would be a massive undertaking for 232 nursing homes. The Medicaid cost reports aren't actually rigorously audited. Myers and Stouffer do a field audit, and there's no requirements by the state or the federal government for nursing homes to submit audited financial statements. So the amendments, to the extent that they would require a new type of reporting on particular nursing home questions, would be a much more realistic proposition for the Maryland Healthcare Commission. I think our only concern with the amendments was the turnaround time required. The first amendments we saw would have required us to turn around information within 30 days. In other words, by the end of January, report on the previous calendar year as far as utilization and financial data. And none of our data systems, or the ones that we would try to tap into, would allow that sort of turnaround. So we would need to be sure that the requirement, if we're going to publish an annual report that covers some of these new issues that you want to explore, would give us the ability to report the most current data available, not something that is literally turned around in 30 days.
All right. So what I heard a few minutes ago was currently the change in ownership issue is being done through Maryland Office of Healthcare Quality. That's available. Maybe it's not easily accessible, but tell me if I'm wrong. And then the information on the trends in utilization, you're telling me that's available as well. And I mean, this Medicaid cost report is for any facility that uses Medicaid. What percentage of our facilities take Medicaid?
Almost all of them.
Almost all. So we're pretty much everybody is covered. Yes. So is there anything that we would be asking for here? I mean, I look at this, and being an accountant myself, it seems pretty broad, a summary of the financial data regarding licensed nursing homes in the state, for the purpose of, I mean, that's a pretty broad spectrum. Is there anything that you think that we would be collecting with this bill that we're not already collecting in the Medicaid cost report? That would be useful for what we're trying to, I don't know, I'm not sure what we're trying to get at, but
well, I think literally, I don't know that I would say that reading the bill would indicate to me that there's more that we need to obtain that we're not already obtaining through our own annual survey of nursing homes, which MHCC does. That's primarily to provide us with utilization trend information that we use in CON regulation. The Medicaid cost reports are something that we bring in from Myers and Stouffer as part of that survey. We do, as noted previously, have public use files that are not user-friendly, I would say, but they do provide access to all of the data fields that are in our surveys. So I think one of the main things we would be doing if this turns into an annual reporting requirement is creating much more user-friendly profiles of utilization and financial information.
And I think
that's,
the amendment on B, on the amendment, it seems like that's what it's getting to. The commission shall publish on its website searchable information on nursing home. So, and including information from and links to cost reports. So you just said that it's maybe not so user-friendly. Maybe that's what we need to do, is just make what we already have user-friendly so people can access it and understand it. So would you agree with that attempt at what maybe we're trying to accomplish here? Instead of reinventing the wheel, just make the stuff in the wheel be more accessible and user-friendly?
Certainly, yes.
All right, I would suggest we consider that might be the direction we go, is, making sure all this information we're collecting is available, accessible, and understandable to people that want to use it. It's just.
Excellent. Thank you.
That's
Thank
the
you,
intent.
Delegate Krebs, for that discussion. We ran out our 10-minute timer on this one. So we will, I think you're kind of heading in the right direction. It sounds like, I don't know if anyone else from the committee has any next steps they want to point to or anything else to add. We'll just sort of stop the discussion here unless somebody else has anything to add right now. Okay, so thank you to all the stakeholders on this. I think there's clearly interest in the problem that's been identified, but maybe we need more work to do on the solution, and the approach to the solution is what I'm hearing. So let's keep going. House Bill 830, State Board of Examiners for Audiologists, Hearing Aid Dispensers, Speech Language Pathologists, and Music Therapists, which is Delegate Lewis's bill. Lisa.
This bill removes the 2 physician members of the State Board of Examiners for Audiologists, Hearing Aid Dispensers, Speech Language Pathologists, and Music Therapists.
Simple. Now, I have not talked to members of the committee about this bill, but we do have a lot of stakeholders here. We just had the hearing. We can rehash the hearing, but I think it's a pretty simple issue, and we're going to need to figure out what to do. So with that, let's see what stakeholders are here. I see Greg Snyder. I see well, let's hear from Delegate Lewis, and who should we hear from on this bill? Delegate Lewis.
Thank you. Thank you so much, Madam Chair. And thank you, fellow members and esteemed panelists and witnesses and advocates and detractors, and everybody is welcome today. Just to refresh the memory of my colleagues, this is a bill that was it has some history in the Maryland General Assembly. It aims to remove the 2 physician members that currently are a part of the Board of Examiners of Audiology. And there is not consensus around that proposal. And I think that all of the stakeholders on both sides of this bill's proposal are here in the room. I've spoken at length over several weeks, in fact, over the last few months, with the proponents and opponents of the bill. The night before the bill hearing, which was just about a week ago, I convened a gathering of proponents and opponents. There were, I believe, 14 people on that call, representing both sides of this bill. And we had a really respectful conversation. I was grateful that everybody came to the table ready to describe their their aims, their wishes, their feelings. And yet we weren't able to find a place, mutual comfort. I think we are coming to you here in the subcommittee with a proposal that needs a lot of deliberation. I've done my part, and I'm happy to hear what the committee feels we should do next. And with that, Madam Chair, thank you.
Thank you, Delegate Lewis. And I will just say that although I normally speak with members of the committee before we have something like this, it's been so hectic I haven't. I did speak with Delegate Hill about this bill because she sits next to me on the floor, and she passed on her question from the hearing. She had a series of questions in the hearings, but her follow-up question, which we may want to include in this conversation, was actually directed to Oluremi Dean, who I see is here. So I hope you can answer it once the conversation gets going. Just put it in the back of your mind. Her question was, would the board be prohibited from consulting with physicians as necessary should they be removed from the board, just talking to them as opposed to having board membership? That was Dr. Delegate Hill's question, which I thought was a good one for us to consider in the context of this conversation based on your testimony. So with that, I see Alicia Spore's hand is up and Greg Snyder's hand is up. Who would like to talk first? I know, Barbara, you're coming too, don't worry.
I will go first if that's okay, Madam Chair. Thank you, and thanks, Delegate Lewis. I just wanted to make like a couple quick points. I know you guys are very busy. So first would be this similar bill was passed in 2003 with near unanimous support from both the House and Senate. Second point would be HB 1155, which the committee passed unanimously this year, and the House passed unanimously, which would make provisions to the Board of Examiners, did not include ENTs as needed to be there for there to be a meeting quorum. Three would be, this would align with other health boards that don't have physician members, including optometry, pharmacy, physical therapy, chiropractors, and ENTs already have a representative on the Board of Physicians. And fourth, I would just add that this has broad-based support from the Maryland Academy of Audiology, which represents the over 500 audiologists in the state of Maryland, Maryland Speech Language Hearing Association, which represents the over 4,000 speech language pathologists in Maryland, and two of the leading ear, nose, and throat doctors in the state of Maryland. So those are just some of our quick highlights from the hearing last week. Happy to answer any questions, and Dr. Spore is here as well.
Thank you so much, Dr. Spore.
I'm going to be brief. I think Mr. Snyder mentioned everything that I was going to touch on, and I'm happy to answer questions along the way as possible or needed.
Thank you. Now we have to hear from Barbara Ricato. Hi.
Hi, and I'll be brief. I want to thank the sponsor for bringing us together, because this took the otolaryngologist by total surprise. Nobody mentioned a word that there was a problem. And I hope you'll take the time to hear from the two physicians that are on the board that are here with us today. They'll tell you directly better than I can tell you. And the executive director of the board, they feel fully integrated with that board. There were accusations that they didn't come to meetings or that they don't participate, and the records show their attendance is average. It's between 80 and 85%. That's what attendance is at board meetings. Things come up.
Barbara, who are the doctors that are here today, so I can make sure to call on them?
Okay, if you'll raise there, and Dr. Nyman is also here. So
Dr. Nyman, Dr. Nguyen.
I'll be brief.
Yes, Madam Chair, those are the two physicians, Tam Nguyen and Carrie Newman. Sorry, Barbara.
That's okay. Unanimously, this board thinks it's working well. Unanimously, the audiologists, the speech and language pathologists, the consumer members, and the physicians on the board think it's working well. It's a collaborative process. It's not a top-down supervisory process. And when we're talking about new integrated models, when we have a situation where there's this cross section of providers that work together and are collaborating in a board capacity, I just urge you not to change that. And I'll say enough and let the folks that are on the board and here with you to please have a chance to speak.
And I think before I call on the two doctors, because we do want to hear from you, I just want to make clear that my impression from the hearing was definitely not that this was personal or about the doctors who are on the board right now. So, you know, we're glad that you're here. I think we on this committee sort of look at the structure of things and what sort of is an outlier structurally about this board. So we really appreciate, I'll speak on my behalf and behalf of the whole committee. We appreciate your service. Service on a board is often thankless. So thank you, Dr. Nguyen.
Thanks for giving me a chance to just chat a little bit about my feelings about this bill. I certainly don't want to be where I'm not wanted, but my feeling about being on the board is that it's been really an honor and a pleasure. It is a little bit, it takes quite a bit of time, and I've really enjoyed working with speech language pathologists, audiologists, HADs, and now music therapists who are on the board, who are all coming together because they're super dedicated to their field, as I am mine, trying to promote the well-being of the public, right? My view of my position on the board is to present an opinion coming from the medical perspective in protecting the public. I have no feeling of being there to oversee anybody or to, tell anybody what they can and can't do. Frankly, I find it fascinating to learn about these fields and the depth and the breadth of skills, and I think I bring that back to my patients with a deeper understanding of these fields. And I think that connectivity and relatedness of our fields is super important. And I don't quite understand the goals of getting rid of us, because I really feel like we're an important member of the community who cares for the same population of people. And so I don't, like I said, I don't feel like there's a hierarchy here. And I get the sense that the narrative is that we're overbearing or something like that. I'm just here to help. So that's my feeling about it.
Thank you so much, Dr. Neiman.
No, I agree with
Neiman,
Neiman. Yeah, I agree with Dr. Nguyen. We have, been active and engaged members of the board for the duration of our service, and I think we bring a different perspective, just like the consumer members bring a different perspective. And while there may be that this seems like an outlier in terms of its structure, there are a number of board of examiners of audiologists and whatnot across the country that also include ENTs. And I think just as Barbara talked about, in the changing landscape of hearing care and much of the care that's provided to Maryland residents, it's rapidly changing. And I think having all of the various views really are a big strength and make us unique. And I agree with Tam in terms of it has been an honor and pleasure, and we are there in a supportive and role in whatever we can do to share our little bit of clinical expertise in the broader picture, in a collaborative fashion. That's been an absolute honor and pleasure, and something that I think really serves Maryland residents well.
Thank you. I see a couple more hands up. So I'll go to Mary Casper, then back to Greg and Alicia, and we have a question from Delegate Bandari. So let's hear from Mary Casper first, and then we'll go to Delegate Bandari and et cetera. Okay, Mary. I think you're on mute. Mary. Mary, we can't hear you. 1 second. Okay, hopefully you're unmuting. You're not muted. It's just low. Okay. Okay, while we wait for Mary to figure out her technological difficulty, let's go to Delegate Bandari's question. Delegate Bandari.
Yeah, thank you, Madam Chair. And it's wonderful to hear the both sides. One of the question here proponent are raising is they can accomplish the Board of Examiners mission without physician oversight. So here was a doctor, what is your name? Is he here still from the board? Yeah.
Yes, we have two doctors here from the board.
Okay, okay, Dr. Chan. Do you think that they can accomplish the board of their board mission without physician oversight? That's one question. And another question is it I would love to know how much state is investing onto physician and whether it is a good use of the state's resources. And the proponent are saying that it is not. Do you want to comment on that?
Sure. Sort of like I said, I don't find that my role on the board is a role of oversight. I don't think I'm there to tell anyone what they can or cannot do, right? I think that because we share so many patients and have just a different educational view of things, that we can provide an opinion on, questions or discussions that might not have otherwise been known, right? I think I spoke with Jen Emeritus a couple nights ago, and when she was president of the board, she brought up, Dr. Neiman is at Hopkins, and she's very research oriented. And I cannot remember exactly what we were talking about, but Dr. Neiman mentioned, oh yeah, we are doing studies on, I think it was over-the-counter hearing aids or something of that sort. And Dr. Neiman mentioned the studies that were, in the works, and the board was enlightened by that, right? So we do provide a point of view, and I think to say, can we be consulted? Of course we can be consulted, but often these things are very organic in their conversations. So we chime in during the conversations amongst the board members about issues, and kind of just provide a point of view. So that's sort of how I view our position. We already cannot vote on matters of scope of practice, expanding or limiting scope of practice for hearing for audiologists and speech language pathologists. We're non-voting on those issues. And I don't quite understand your second part of that question.
Compensation. Can you talk on the compensation part? How much does it cost for the state to have two physicians on the board?
I honestly don't know how much we make per session, and I have not submitted any of the receipts for compensation for me coming to the board meetings in the last 6 months or something.
I can answer that question if you don't mind me jumping in.
Go ahead, Ms. Dean. Hi.
Hi, I'm the executive director for the board. So our physician members only receive $75, per meeting. So it's for the both of them, we're talking just $1,500 total per year. So it's not much fiscally. We wouldn't really have a major impact if we removed our physician members that we would be able to utilize for our budget. And also to add on that, we also have an audiologist from the board on the call as well. Dr. Stacy Samuels Cole is also one of our audiology board members, if you all had questions for her as well.
Excellent. I think we're going to go. So we are out of time on this conversation, but I'm going to go over a few minutes because we want to hear from Ms. Casper. I think she's signed on in a new device. Mary Casper.
Thank you, Delegate Kelly. I hope everybody can hear me now at this point. We
can.
Thank you. So I appreciate all of the service that the two currently serving physicians on the board have provided. And I absolutely appreciate interprofessional collaboration. I think where we need to take it away, as you advised us, from the personal side of things, to considering the structure of the board, The board represents 4 disciplines: speech language pathologists, audiologists, hearing aid dispensers, and music therapists. And so there's already a great variety of that interprofessional collaboration that occurs and happens in the business of running the board. And so from my perspective in supporting this legislation, what I'm saying is, I don't know why we have members of the board who are not consumers that are speaking to anything, whether you're a voting member on practice issues or a non-voting member. In my experience, the board should be comprised of those professions that it's supporting and regulating and licensing. And so I'm just struggling with, not on a personal basis at all, and not recognizing the value that Dr. Neiman and Dr. Huen have added to the work of the board personally. And when their terms end, I'm still going to have the same question about why it is that we need anybody on the board who is not overseen by that board. So thank you.
That I have so many hands up on this. I feel like we could discuss this forever, and we don't have forever, unfortunately. I'm going to go to Dr. Spoor because her hand has been up forever too. But I'm going to suggest the committee members need to think about this, I guess. Learn more. I think we're just going to have to make a call, and I think that's kind of where we're going to be. So the bill will come back up. Dr. Spoor.
Yes, thank you, Chair. I appreciate that. I can't reiterate what Mary Casper just said in terms of none of this is personal. And we work with physicians on a regular basis, just like our other colleagues, but there's no guarantee that moving forward, if the board stays as is in this system, that the physicians in the future may or may not be collaborative and may or may not submit their actual reimbursement to the state. And I often feel like when we talk about expenses and I take it to a consumer and we say, well, the fiscal note's only $1,500 a year, that's one hearing aid for a patient. And that's, 3 or 4 or 10 speech pathology therapy visits. And so we're talking about things that could really go back into professional development. And that's an important feature for some of them, but it's not nearly as important to the fact that phone calls and Zoom meetings can be done and we can work collaboratively without having somebody there all the time. And then looking at other board compositions, we know that the pharmacy board is super important to physicians, especially with the opioid crisis and some of the other issues going on. And there's no physicians sitting on their boards to oversee that oversight of where those prescriptions and those drugs are going. And I think that's a little more relevant. And I would think that they would want to be there if they were truly wanting to be, part of that healthcare system within the entire thing. So with the fact that this passed, almost 2 decades ago, I'm just asking for a favorable response. And I'm also happy to answer any questions from anybody at any point in time. Feel free to reach out. That's why Bellamy and Jen and the speech pathologists and the audiologists are on the board. So thank you very much, Delegate Lewis, and thank you, Delegate Kelly.
Since we have Ms. Dean still here and with her hand up, I'm just going to close the conversation. I know you have your hand up, so there must be something you want to add, so I will let you add it, but also the question I started with, which was Delegate Hill in this context, please. Delegate Hill's question, which was about doctors. I remember from your testimony, you noted how helpful the participation of the physicians was. Would you be able to consult with them outside of their board service, consult with physicians as needed? Is that prohibited? Would you be allowed to do that should this bill pass? And then whatever else you'd like to add.
So if the board in the future, if this bill passed, wanted to consult with a physician, we would have to hire a consultant to be able to do so. So we would have to actually reach out to a physician member and we would pay them for their services for coming in and speaking with the board. I also wanted to note that I know that, again, the term oversight and supervision keeps coming up. But, I just want to definitely make clear that our physician members do not oversee our board members. Also, in regards to their contributions, unfortunately, I could not deliver a transcript of our meetings. We do not keep transcripts of our meetings for open or closed session. But I can say from my experience that I've witnessed that our physician members collaborate and participate in all discussions that are held with the board, and that our meetings will only reflect what decisions were made by the board as a whole. It won't actually mention who discussed or participated in those discussions. So that's all.
Thank you so much. So committee, we will be coming back to this, and I apologize. We ran way over on that, but there was a lot of folks here, and so I apologize. And we will move on to the next conversation, which is on House Bill 911, Health Occupation Psychologists, Doctoral Degrees, which is Delegate Bagnall's bill. Lisa, can you remind us about this bill?
This bill modifies the definition of doctoral degree in psychology to include a postdoctoral respecialization certificate from a program that at the time the certificate was awarded was offered through a degree program that is accredited by the American Psychological Association or the Canadian Psychological Association. There is an amendment on page 9 of your packet, and this amendment clarifies that the postdoctoral respecialization certificate is practice-oriented and issued by an accredited department.
Excellent, thank you. Delegate Bagnall.
Thank you, Madam Chair. There's not a lot to add on this. We have requested a meeting with the board. I know that the Board of Examiners for Psychology were opposed to this. We did try and address some of the opposition in the hearing, but we have not been able to coordinate a meeting to see if there was a place for compromise.
Okay, do we have stakeholders here on this bill? Is there anybody here who wanted to speak on this bill? I see.
Yes, we've got Dan Martin, Mark Trollinger, and Dr. Savage, I believe are all.
Excellent. So do we have anybody from the psychology board here today? I don't see anybody, so that makes it harder. So I'm hearing you're having difficulty setting up a meeting and we're not getting them at this meeting. We just had the hearing, so I will call on the stakeholders to clarify, but I think the hearing is probably fresh in people's memories. Should we hear from Mark first? Go ahead. Thank you.
Yes, I would just like to bring up again many of the points that I brought up, that a lot of the information that seemed a concern to the State Board of Examiners was just based on information that I'm not sure where it came from that is not accurate. So when people do a respecialization, they actually go through the actual same application process as those who are applying to the APA accredited doctoral degree program. They get credit only for the research courses and dissertation, unless they can transfer in up to 12 credits if they took a course that was actually the exact same course. And I want to give an example of what that is. For example, in my PhD, I took a class that was cross-listed. It was neuropsychological assessment. It was cross-listed. I had to take it for 1 extra credit because I was focused on the international perspective and how to deal with people who fall outside of the norms. But because I met all of the requirements of the 2 credit hour degree course, and I literally sat in the same classroom as the APA accredited people who took that course, then in that situation, I was able to potentially earn transfer credit out of the 2 universities I've been accepted to. One of them said yes, one of them said no. But the point is I was literally in the same class. So people who take these respecializations literally have to sit in the same classroom. They go through the same application process as everybody else. They just get credit for having already done a dissertation. So where the other information came from, I'm not entirely sure. So I just wanted to point that out.
Thank you for that. Do you have anything to add, Dan?
No, just just what we said in the hearing. We have a really terrible workforce crisis going on in the state. And we need anybody that's qualified, willing, and able to provide services to folks. Mental health services to folks to be able to do that. We need to remove barriers for that, and that's all this would do. And like Mark said, I don't think that the board's concerns are terribly convincing. It's not different or less coursework. It's literally the same coursework. It's literally the same practicum experiences, and the same amount and quality of supervised experience. So it seems like a simple, easy thing to do to kind of help a little bit with our workforce issue. And so I would just encourage us to, so yes. So and Dr. Savage from the Psychological Association's here too. So thank you, Delegate Kelly.
Excellent. Let's hear from Dr. Savage.
Hi, thank you for having me back. I'm not going to repeat the information you just heard. I agree with all of the points so far that have been made. The language in this bill was gone over multiple times by members of our legislative committee in consultation with them. We actually had some people from APA involved in helping us craft the language to make sure that it was crafted so that people, A, would be eligible, and B, they would be trained equivalently to any person coming out of an accredited program. I think the last thing I would say, just in terms of the crisis, to give you guys a sense of it, I am a non-network provider, so I am out of network. I have a very small private practice. I am full-time, and I turn away 27 to 30 people per month that I cannot manage in my practice. That's how big the need is in the community. So we're strongly in support of it. To any small step we can take to get qualified mental health providers out there for the public to access, I think would be a great thing to do. Thank you.
Thank you. And I will just note that we did invite the representatives from the board. We have not seen them here. So do we have questions from the committee?
Hi, this is Lorraine. I'm from the board.
Oh, you are here. Oh, good, good, good. I'm glad you're here. I was asking for you earlier. So please, why don't you weigh in now?
Okay, hi, I'm Lorraine Smith and I'm the executive director of the board. And as you read in the board's position paper or letter of concern, is that the main concern is the fact that a degree in a clinical psychology degree would still not be awarded to the candidate. Currently, the law requires a clinical psychology degree. And typically, these respecialization programs are, and they came about for those with a clinical psychology degree. Let's say, for example, that they specialized in forensic psychology, and they wanted to also begin to specialize in, let's say, custody. So they would take this certification classes in custody psychology. And so therefore they could actually consider themselves trained in in forensic psychology and as well as custody psychology, but they already have a clinical psychology degree. In this case, this situation, we're looking in this particular example here, this person and most of these schools now, people coming for this respecialization may or may not, well, if they have a clinical psychology degree, it's not a problem anyway. They would be eligible for license. But here they are taking courses and they are awarded a certificate. And yes, these courses are within a program that, and the law says, the bill that you're putting forward, it says that the program has to be within the APA approved program, which is good because there are other universities out there that are offering recertification programs that are not clinically approved or not approved by the American Psychological Association. So are we opening up a whole nother level here? Number one, we're not talking about clinical. We're talking about taking courses that typically those with a clinical degree would take in order to enhance their knowledge. But now we're talking about people who don't have a clinical degree, but they take clinical courses and they receive a certificate. So that, and so the board, again, the board is not opposed to expanding providers by no means. And the board is more than willing to look at this more closely and to even work with some universities if necessary, just to make sure that we don't leave any loopholes open and that we don't lower the standards of our services and for licensure.
So I really appreciate you being here and you walking us through that, and really appreciate your willingness to work on this. I'm going to request that you work with the sponsor over the next week because we do have this legislation before us. So if you can sit down and meet with her and go through and come up with those specific concerns and look for loopholes. I have Dan Martin's hand up, so we'll go to him, and then we have a question from Delegate Bhandari. Dan.
And I just thank you, Delegate Kelly, and thank you, Lorraine. I appreciate you joining the meeting. But I just want to say, so are you speaking directly to the bill as drafted or with the sponsor amendment? Because there is an amendment that was offered to make it a practice-oriented postdoctoral respecialization certificate. So would that address the clinical concerns that you're talking about?
Well, and Dan, let's keep this conversation with the legislators asking the questions, but
I'm
you
sorry.
raise
I'm
a
sorry.
very good point. So thank you for addressing that. And I'll just say, Lorraine, meet with the sponsor, go over the amended bill. Let's see if your concerns are addressed, and we're going to come back next week. And I'm going to hope that if your concerns are not addressed, I trust the sponsor will look for ways to solve any substantive problems, because we all clearly share the same goal of trying to address this provider shortage. Delegate Bhandari.
Thank you, Madam Chair. This question is to Ms. Lauren. Based on your written testimony that you guys have issues like, this bill presents many variables that can lower the current standard of care and reduce the protections of the public. And based on the conversation from other side, they have already the PSD and they do take all the re-specialization programs. And I understand that they have a less clinical based coursework and the supervision, but already they did PSD and they have knowledge on the research field, and they already have a coursework requirement as well. Can you share your wisdom how it will be the lower standard, like lower the current standard of care and reduce the protection? Briefly, Ms. Lauren, could you share your wisdom?
Oh, I think you're on mute. Oh, technical difficulties. We were waiting for your wisdom. It sounds like we're not able to hear you, and our timer is about to run out on this conversation, but I think we do have some next steps. Delegate Bagnall, can I put this in your capable hands, and you guys will do a meeting and we will bring this back up?
Yes, we've already put out a request to get a meeting with all of the stakeholders. Lorraine, thank you so much for being here today and for being willing and available to have these conversations. I'm sorry we're not able to hear you, but we'll get a meeting on the books, and we'll get to work on this. So I do appreciate you being here today, because obviously we all have the same end goal.
Excellent. Thank you so much. And we will pick this one back up. 2 more bills left on the agenda and 4 minutes left for them, but I think they're both in a somewhat similar situation where we may not have the amendments we need ready, but we can have a 2-minute conversation on each, so at least the committee gets an update. House Bill 972, Continuing Care at Home Certificate of Need Exemption. Lisa.
This bill would exempt continuing care at home agreements from certificate need requirements by altering the definition of healthcare facilities for the purpose of providing an exception to the requirement for a certificate of need. The amendments that are not ready but are being prepared now would provide that a provider that satisfies the capital reserve requirements does not need to satisfy the requirement for obtaining a specified number of pre-sale agreements.
And I'm not sure about that amendment, or if we need it or if we don't, and we haven't, I think we're sort of not necessarily up to date on that. So let me toss that to Aaron Greenfield, and he can give us an update on where we are with this bill.
Yes, thank you, Madam Chair. So I think the bill is ready to go with the exception of one amendment that would eliminate the pre-sale enrollee requirement, which I know Leading Age, Maryland, and I believe the other industry groups, I don't want to speak for them, but we have no opposition to it at all and would support the bill moving forward with that amendment.
Okay. Any other stakeholders want to speak on this right now? It looks like there is Brad Paulus or Arnold Eppel can speak on the amendment. So Arnold, I see you. Are you here? Do you want to speak to who wants to speak to the amendments?
Well, let's have Brad Paulus speak first.
Excellent.
Thank you, Madam Chair and delegate subcommittee members. I'm a partner with Continuing Care Actuaries, which is located in Reisterstown, Maryland, and we specialize in supporting CCRCs and continuing care at home programs nationally. I've been doing this work for over 30 years. I'm also on the board of the Wesley at Home. When we look at the states from Virginia to New York and out to Ohio, there's 13 continuing care at home programs in 5 surrounding states, but currently we don't have any in the state of Maryland. And there's really 2 aspects of the current regulations that have inhibited that growth. And one is the closed CON issue. That's the main focus of the bill. And the second is the pre-sale issue. There's already currently reserves on the books for at-home programs in the state of Maryland. There's a capital reserve initially, there's an operating reserve, and there's a contract reserve. No other state in the nation develops that capital reserve. New York's the only state that requires a contract reserve, and a few other states require an operating reserve. We're not questioning any of those reserves. We actually think they're appropriate and well-designed. But Maryland's program is the only state in the country that requires these pre-sales. And we view the capital reserve as and the pre-sales as really duplicative requirements. They're both trying to protect the early members in a program, and having that capital reserve does that. And so we really feel that having those pre-sales actually inhibits the growth of the program. You're asking members to sign up and pay money before they're actually getting anything. And so we view that as a barrier in terms of the growth, and it's really slowing or halting the growth. And it's why programs have not come into the state of Maryland and developed these programs.
Okay. There's so much. Sorry. It looks like Tracy DeShields has her hand up. Tracy, did you have something to add?
Yes, hi. I just wanted to mention that MHCC has not seen the amendments or the proposed amendments, and so I think we would really want to review those.
Yeah, we're not going to vote on this week. I don't have an amendment yet either. So we're discussing a concept, but we're going to come back to this bill for sure. And we'll make sure that all the stakeholders have the opportunity to weigh in on that. So
great. Thank you.
Thank you for raising your hand and noting. We'll make sure that everybody gets to take a look at them, and we'll continue this conversation. So I think we'll just, unless there's anyone else who has something, Arnold, did you want to weigh in on the bill? Go ahead.
I did, because this program has, I appreciate your time, Madam Chair, and all the delegates and subcommittee members and other industry experts. I've worked for 2 departments of aging. I ran Catholic Charities, Division of Aging, HUD buildings, nursing homes, assisted living. And this program allows Marylanders to self-fund their long-term care. We have so many older adults who end up on Medicaid at end of life. This program really allows these folks who potentially either forgot to buy long-term care insurance and need extra help to stay in their home with case management services. This bill really allows, it's very difficult. It targets a 75-year-old typically, even though it's 60 plus, but it's hard to ask 75-year-old who's seen many things in their life, the various difficulties, they're leery and mistrusting. And then every time we go to talk to someone, they let us know, let me know when you have the other 29 people interested. And so it's a severe barrier to this program. And that's the reason there are no, we have a preliminary certificate of registration, but can't go into operations into these 30 pre-sales. Brad's noted the various capital reserves that are around. Many providers have looked at Maryland, but they're not coming in because of the 30, this 30 barrier. So I respectfully request your review of the amendment. I appreciate everyone's time.
Excellent. And and I'm sorry to bring this to the subcommittee because normally we would take care of this before it comes to the subcommittee. And this is my bill, so I'm the guilty one here. I think this is an important bill and I want us to be able to move the bill. I would love for the subcommittee to consider and discuss the amendment, but we don't have time to do that right now. But it's important to me. So I just want to hear the people who are proposing the amendment. It's important to me that all the stakeholders be on board and that everybody be okay with it if we were to put this amendment on, because I don't want to harm the original bill, which I think we all, I can't speak for my colleagues, but I would like to see passed. So we will hopefully make sure everybody gets the amendment and that all the stakeholders are on board and comfortable with the amendment. And those conversations need to happen before the next subcommittee meeting so that we can present a clear story to the subcommittee. With that, let us just touch base really quickly on the vice chair's bill. We won't have time for a discussion because everybody needs to break for lunch, but let's do 2 minutes on House Bill 1034. Lisa.
This bill renames the State Board of Examiners of Nursing Home Administrators to be the State Board of Long-Term Care Administrators and requires that an individual must be licensed by the board to practice as an assisted living manager in the state beginning October 1st, 2024. There are 2 amendments in your packet. The first one is on page 10. And it reduces certain civil fines to $1,000 for a first offense and $5,000 for subsequent violations. And then a second amendment on page 11 establishes a civil fine of $20,000 for practicing without a license or aiding an unlicensed individual. And then there is one other set of amendments that are still in the works that we don't have yet that make a lot of different changes that the industry was interested in.
So I understand that Michelle Furman is here on behalf of the vice chair. And as I understand it with this bill, we're still working on the details of the amendments. So we will be okay to take up this conversation next week. Does that sound good?
Yes, that's correct.
Excellent. So any questions from the subcommittee on that, or shall we take our lunch break? I don't see any hands up. So with that, I'm going to adjourn this. Before I adjourn, I'm going to remind the committee that, as you can tell, we have a lot of bills. We're going to have a whole lot more next week. So I expect we will be adding an additional meeting, probably not next week, maybe the week after, but we will get to all the work before the subcommittee. Thank you so much. Meeting adjourned.